Good evening, it's 8 o'clock and welcome to today's episode of Marvelous Medicine. Today's topic is simulation as a tool for healthcare improvement. This session has been a long time coming. I think we planned it 3 times and for various reasons it got postponed. The speaker is Dr.Thilaka Muthaiah, a dear friend and an ex-colleague. She is the clinical lead Apollo Simulation Center, Chennai. She did her MBBS from Madras Medical College and her MD Anesthesiology from All India Institute of Medical Sciences, Delhi. Thilaka is the national editor of the Chettinad Health City Medical Journal, which was started by Professor Pandian, who's also logged in. And she's also a reviewer of the Indian Journal of Clinical Anesthesia. Thilaka has over 15 publications to her credit and a book chapter, and has also delivered more than 15 talks as guest faculty. Now fully into simulation-based training and research, and I could not think of anyone better to talk about this. Joining her will be Dr. Rashmi Ramachandran, whom Thilaka considers her simulation guru. She is the professor and head of the Department of Anesthesiology, Pain Medicine and Critical Care at All India Institute of Medical Sciences, Delhi. Dr. Rashmi did her MBBS, MD and DNB anesthesia from Lady Harding Medical College and her high fidelity simulation training from Mainz, Germany. Dr. Rashmi's areas of interest include obviously simulation, skill teaching, renal transplant anesthesia, airway management, and pediatric anesthesia. Dr. Rashmi has over 70 PubMed index publications and 5 book chapters. Thank you, Dr. Rashmi, for agreeing to join the session so spontaneously and so quickly to our request. And
thank you, Dr.
That we have a good time.
Yes, sure.
Co-moderating the session will be Dr. Geeta CR. She is the professor and head of Department of Anesthesia at MS Ramaiah Medical College and Hospital. Like I mentioned earlier, I was introduced to simulation-based training while attending one of her workshops. It was truly inspiring. No other sessions have actually come up to that standard after that.
Thanks.
Did her MBBS from KIMS Bangalore and DA from KMC Mangalore, and her DNB anesthesia from Ramaiah. So from being a DNB PT, she has become the professor and head of the department. So that shows her caliber. She's also done her PG diploma in hospital and healthcare management from Indira Gandhi National Open University. Dr. Geeta's special interests are obstetric anesthesia, onco anesthesia, difficult airway, and obviously simulation. The BLS, ACLS, and trauma life support instructor. She has several publications to her credit and has been faculty in many conferences and workshops. Thank you, Dr. Geeta, for readily accepting to join this session. Over to you, Thilaka.
Yes. Thank you, ma'am. Thank you. I'll just share my screen, ma'am. Is my screen visible, ma'am?
Yes.
Yes. A very good evening to all of you, and thank you so much, Vidya ma'am, for the really kind introduction, and thank you for this wonderful opportunity to present on simulation as a tool for healthcare improvement. Simulation, as we all widely know, is a technique that replaces or amplifies real experiences with guided experiences in a safe environment whereby the learning curve doesn't really affect patient care. We can replicate substantial aspects of real world in a fully interactive manner. And with research and experience, simulation-based medical education has been shown to promote acquisition of new skills, maintenance of those skills, and so obviously it leads to enhanced confidence of the healthcare provider. Also, when we do team trainings together, it leads to definitely better team coordination, better communication among team members and also with the patients, and hence it kind of helps in a positive change in attitude for anybody who has exposed in simulation. So currently, all these benefits of simulation has been identified by everybody, and it is already integrated into the medical teaching as well as the nursing teaching at the undergraduate level. Slowly, it is to enter into the postgraduate curriculum as well. So currently simulation, as it is being taught as a more training-based approach in medical colleges and hospitals, is a more patient-centered approach towards safety, where that person becomes more skillful and so they are safer to patients. And also when teams train together, there are decreased number of errors and hence enhancing any kind of healthcare improvement. However, there is very limited understanding on how long the benefits of these simulation sessions persist. What is the actual impact on the clinical outcomes in the areas where patients are really treated? And what does simulation do exactly to safety and quality? So in the next few minutes, we'll discuss about how simulation can actually be used as a tool for healthcare improvement. So we'll touch upon a few topics like transfer of learning. We will definitely talk a lot about why simulation and quality improvement have to be tied up and have to work together. Also, we will look a little bit about how we can implement, of course, the challenges and definitely the way forward. By transfer of learning, we mean that when people can apply information, skills, or any kind of strategies that they have learned in one environment to a completely new situation or a context. Say, for instance, they learn team training in the simulation center. We hope and we always expect that it will become a good team training in the resuscitation area or in the clinical area. Though we really wishfully want it, it is not always automatic and it is definitely not so straightforward. So in an interesting paper, they actually discussed how simulation-based medical education actually qualifies to be called translational science. So usually this word translational is used in biomedical and in research facilities, where T1 outcomes will be to bring whatever happens in the laboratory to a clinical research area. And the T2 outcomes would be to show that whatever the intervention is actually causing good clinical outcome in patients. And T3 outcomes would be overall health improvement and development which will help population at large. Similarly, in simulation, if we look at resuscitation, training somebody in CPR, ensuring that they perform well, would be a T1 outcome. If the same person goes and performs good resuscitation, if they are able to follow good team dynamics, then that becomes a T2 outcome. And if we can actually touch upon a faster recovery, a reduced length of stay in the hospital, not just for that patient, for many other patients, that would become a T3 outcome. So now if we want simulation to have an impact on healthcare, two units inside a hospital or two workforces within a hospital. One is the simulation department and the other is a quality improvement department. Now, both these departments always work together. They always are looking at how quality can improve. They are always looking at patient safety. They are always looking at reducing errors, but they work in silos. So they work separately. These two, simulation and quality improvement, has to be integrated with health. It has to be integrated. And this integration has to be routinely into the structures and practices of healthcare. Now, if I give an example, it will be easy to understand. Say, for instance, this is a hypothetical example. It has not happened anywhere. Say, for example, the internal audit of a hospital finds out that a critical care patient, when shifted from the ICU to the CT console, they observe there is a drop in 20 to 30% in blood pressure, or hypotension almost always occurs. So now what happens? The hospital quality team sits and brainstorms on how this happened and why this happened. So these are again hypothetical. Say, for instance, they come up with things like insufficient battery backup in the infusion pump, near empty syringes during transit. That's why the syringes could not be changed. Of course, knowledge gap, which we all know definitely occurs in most of the areas in even day-to-day clinical medicine, knowledge gap among a few members, and the CT console probably not alerted about patient transfer. Now, the QI team or the hospital quality team will not touch upon all these things. They will try to address that one issue which will have maximum impact on patient outcome. And say, for instance, insufficient battery backup in the infusion pumps have led to 80% of the events happening. So then what they will do is they will identify why it has not happened and say, put on a charging station for unused infusion pumps. And of course, a protocol will be ensured to make sure that pumps with 100% battery backup only be taken taken during transfer. Now, this will definitely reduce the number of hypotension episodes that happens from the ICU to the CT console. Now we will see what will happen when the simulation team and the QI team work together. The simulation team and the QI team can together form a structured simulation exercise, which can be conducted at the place of work itself to train all the members. So all the gaps that were mentioned before can be addressed, not just all the gaps. In addition, during the process of simulation, automatically other potential areas of concern, if they are existent, say for instance, a delay due to inadequate planning to stop the lifts, or the patient trolley hitting against the walls multiple times, which today is not a threat, but can potentially become a threat later, can be identified, and even those areas can be addressed. So, in situ simulation or simulation that takes place in the clinical setting is one of the most excellent ways to explore working environments. Now, why is in situ simulation very, very useful? Is because all of us work in clinical areas and all of us are well aware that nothing is perfect in any clinical area. Clinical practice almost always happens under conditions of considerable complexity. There is always some kind of change, some kind of surprise. So when in situ simulation happens, it not only satisfies the original goal of simulation, where there is opportunity to practice technical, non-technical skills and also to address concerns, it also helps us to identify and remedy latent safety threats. Say, for instance, in this picture, suppose when it happens in the clinical area, say this drug cart has a specific mechanism of opening. And if people who are part of the simulation team are not able to open that, things like whether the defibrillator is actually plugged to a charging point, so things which are there physically present, where is the drug kept, where is the syringe kept, are the syringes correctly discarded in a proper way. So things like that, if they are not happening correctly, can also be identified when in situ simulation is conducted. Another great thing that in situ simulation does is it can help us identify and enable tacit expertise as well as positive deviance. Now, what do we mean by tacit expertise? Now, tacit expertise is the kind of knowledge or the wisdom that happens with time, which cannot be actually put in words. Say, for instance, a seasoned clinician will be able to tell because of something. There is a gut feeling that happens when a patient deteriorates, though the vitals are not too deviated. They'll be like, no, I think this patient is not doing well. This patient should be put on oxygen. Kindly connect a pulse oximeter and shift him to a more monitored area because something might happen. So that is called tacit expertise. And what is positive deviance? In every community, there will be a certain group of individuals. So all of them will be, even if all of them are given the same kinds of problems and the same kinds of resources, some people come up with better solutions. So these people are called positive deviants. These positive deviants are present throughout healthcare system. It is really important that we identify these positive deviants so that the same behavior can be easily replicated among other members of the team. So in situ simulation gives us a wonderful opportunity to learn from these successes and to ensure that positive behavior can be replicated among team members. Slowly, also, there is a paradigm shift in how safety is being perceived. In a white paper that discusses about safety, which is there in the NHS by an author who works at the NHS, called Safety One Approach as ensuring that as few things as possible go wrong. Whereas Safety Two approach is ensuring that as many things as possible go right. If I have to put it in an example, suppose there are 10,000 events and there is a one failure per 10,000 events, then this red area will determine the failure. And all of this green area, which means 9,999 times failures have not happened. Does it mean that in all these 9,999 times, everything was completely perfect? No. But something somewhere led to non-failure, or something somewhere prevented failure from happening. So now there is a more concern about what is it that is preventing failures from happening. I'm not trying to say that identifying problems or addressing any kind of near misses is not important. Of course, they have to be identified. But how many times has somebody been told that they do good job, that despite all the shortcomings, the teams have actually made the person survive? For instance, say in Dr. Ramesh's pediatric OT, in 4 years' time, 4 times laryngospasm has happened, which will be discussed to great detail, whereas 4,000 times children are extubated without having laryngospasm. So how is it that 4,000 times children are extubated without laryngospasm is also a huge area that we should explore. We should kind of identify, and we should appreciate the fact that so many things go right despite problems so many times. Another area where simulation can significantly affect healthcare or for the better would be to improve clinical performance and outcomes. So usually these clinical performance and outcomes can be time-based targets, like for instance, time to thrombolysis or time for trauma patients to reach the CT area, or easily measurable indicators like resuscitation outcomes or teamwork in trauma. A wonderful study conducted by the Norwegian Stroke Center by Ajmi et al. Showed how quality improvement and simulation worked together to reduce the door-to-needle times in stroke thrombolysis. So their center already had a door-to-needle time of about 30 minutes, which is perfectly all right. But what they wanted to do is to reduce it even further, and they wanted to see if it can happen. So the quality improvement team brainstormed and looked at certain areas where they can reduce time. And so they thought of all those things and streamlined the protocol. Then the simulation-based team was brought in to train all members of the team with the new protocol that was formed. So 14 sessions were conducted over a period of 4 months. Another 4 months of gap was given, and an additional 12 sessions were conducted. Finally, when they looked at the results, they assessed about 650 patients. Of course, they included both pre-intervention and post-intervention. By intervention, they mean the simulation sessions that were conducted as interventions, or the policies which were implemented as interventions. So when they looked at 190 post-intervention patients versus 399 pre-intervention times of door to needle, this is the data that they have given. And this vertical black line is the time where they implemented the intervention. So pre-intervention, the median time for door to needle was about 27 minutes, which after intervention significantly dropped to 13 minutes. Now, the beauty in this study is it was not a one-time event. The result that was caused actually lasted for over 13 months, and it was a consistent effort. And also the time of the day didn't vary the result. Whether the patient landed in the morning or in the night or at any time of the day, the results were still consistent. So simulation and quality improvement, when they work together to improve some kind of outcome, this is the kind of effect that they will have to patient safety and healthcare. And another area where simulation and quality improvement should work together is when there are areas that need to be tested. There are new areas which are post-construction, before occupation, before any kind of occupancy. In this study, what they did was there was a new hospital, and there were subspecialty outpatient clinics that were built. So The QI team and the simulation team tried to work together to find out if there are latent safety threats. They conducted 31 simulation sessions over a period of 3 months, including 150 participants. Now, the participants were volunteers, people who were working in the place, nurses, housekeeping, doctors, and everybody participated in the study. And they identified 334 latent safety threats, of which 36 were very high priority safety threats, which means they directly affect patient safety, as well as they have an effect on infection control. So once they identified that, obviously the next step would have been to correct those safety threats. So now we are repeatedly looking at simulation integrating with quality improvement. So if at all such a kind of integration is successfully implemented in all hospitals, so what will happen? Now, relationship between teams is usually a very, very less explored area in healthcare. Say, for instance, relationships between the nursing team and the doctor's team, because the nurses feel that they are overburdened with work. The doctors feel that the nurses don't follow orders correctly. Relationship within the doctors, no anesthetist like surgeons because they, for whatever reason, and the surgeons hate anesthetists for canceling cases. So when there is relationship issue like this within a healthcare system between teams that have to work together, we've never tried to explore these relationships. But with quality improvement and simulation, we can actually explore these relationships to create a positive culture in the workplace. Also, because these teams, all the teams that work together, when they also train together, it kind of fosters a lot of familiarity between the team members. They know each other's by name. And when they come for a simulation exercise, and then when they debrief and when they talk among each other, and when there is a break without any kind of patients, when it's a non-patient involving thing, generally they feel light, and they start moving in a more friendlier fashion also. And because all these happen, the healthcare professionals kind of feel more engaged, and having an engaged healthcare professional can lead to literally magic in any clinical area, because an engaged healthcare professional will always think about what best to do, and they will always deliver the best. So all these put together will create what is called a psychological safety in the workplace. Now, psychological safety in the workplace means everybody functions to the best capabilities. And when there are errors or when there are problems, people don't feel afraid, or people don't have a concern in raising their voice because they are not being judged. That is exactly psychological safety. So before an error can happen, people actually voice out that this is a concern and probably this needs to be addressed. And the work environment becomes really beautiful when psychological safety is there in each of the working places. And inculcating habits, small habits, routine habits like debriefing to marginal gains, which means exploring what went well and what could go just 1% better at an individual, team, or systems level after every team activity. Say, for instance, after finishing a case, or after shifting a patient, or after a resuscitation, just 1% better. So here, what are we actually signaling to the healthcare providers? Now, we are not giving them endpoints. They are not running towards achieving endpoints. They are not running to prove anything to anybody, whereas we are giving a clear signal of improvement as a priority. So every single time there is 1% better. So there is no end to how much the system can become better at all. This was a very interesting drawing. Till the time, at least I saw this, there was always safety and quality was one and the same. But this paper beautifully explains what safety and quality mean. So safety is the bare minimum standard that every patient will get. That is, no patient will get anything below this level. So safety actually sets the floor of a healthcare, healthcare improvement, or of quality. The safety sets the floor, whereas quality is how much better can we do? What is the expertise? How well can we perform? How much can we perform? What is it that we can maximally do to the patient is quality. So quality sets the ceiling. For healthcare systems to improve, safety has to raise the floor, and quality improvement has to raise the ceiling. Now, both these, raising the floor as well as the raising the ceiling, can happen with simulation. Usually what happens is simulation experts kind of try and push ourselves into a clinical environment. Say, for instance, if I want to run an ED scenario, or we think that, okay, fine, probably giving training for rapid training for everybody, how to do a crash intubation will help. So let's just go and do a scenario. So that is how we kind of push ourselves into the healthcare system. We try to figure if this will work. We try to find out results. We try to do all these things. Whereas the original thing is the simulation team as well as the simulation experts have to be pulled into the existing QI system. So there should be a system where quality will identify, okay, fine, now this is an area where simulation can come in and help us. So let's just call the simulation team. Let's brainstorm with them as to how this kind of a training can go ahead or how we can address this. And then simulation has to work with quality. So currently there is a lot of pushing, but technically there should be pulling into the existing healthcare system. So then how do we integrate? So we have to align simulation with the contemporary approaches of quality improvement. So both from quality as well as from simulation, we should not have any kind of conflicting or competing agendas, philosophies, or claims regarding equipment or infrastructure. And when any hospital identifies a simulation expert, usually simulation experts have good skills in reflective conversations. So whenever they are put in an environment, they kind of ensure that the environment feels psychologically safe. They can make people talk. They can make people reflect. So when we have experts like that, they should be pulled into clinical event debriefing programs for healthcare teams. So they might not be the subject experts, and they don't have to be the subject experts. They can be subject experts to clear all the technical aspects of it. The simulation experts can only help in reflective conversations. And when we see, barring a few healthcare management journals, most of them do not publish simulation-based healthcare improvement in healthcare management journals. But if we start publishing more in healthcare management journals, then simulation will probably be identified as one way, one definitive way in which healthcare can improve. And words like translational simulation matter, because when we talk about translational simulation, there is automatically a focus. So simulation is identified as a program with more focus on quality improvement and more focus on patient translation. And there is always clarity on purpose when such terminologies are used among people. And strategically, though, I mean, I know that this is not possible in all the centers, but simulation centers have to be placed within the premises of the hospital whenever possible, because then it kind of sends out a clear signal that they are part of training. And now what happens is simulation centers are associated with universities, they're associated with medical colleges, they're associated with nursing colleges. So there is a brain barrier thinking that only pre-professionals, only students, only people who are not technically versatile in their skills have to go to simulation centers for training, because the centers are for their purposes. There should be a clear signal that goes out saying that simulation is skilling, upskilling. Simulation is team training. Simulation is patient improvement. Simulation is healthcare improvement. Simulation is quality improvement, which means everybody who's in the healthcare system, being nurses, being doctors, being heads of the departments, anybody who is anywhere in the ladder can actually approach the simulation center when they want to, say, for instance, practice something. And there should be no, somehow there is always a barrier when we ask healthcare professionals to come for training. It really doesn't mean that we are not good at our jobs and that's why we have to go for training. It can just be to enhance whatever we already have. So that kind of signal always goes when simulation centers are located within the premises of a hospital. Now, I don't want to misunderstand this sentence to be misunderstood that all hospitals should have state-of-the-art simulation centers for healthcare improvement to happen. No, that is not what I'm trying to tell, because simulation is more of a technique than technology. So that is a completely different thing. But when simulation centers can be placed within the hospitals, definitely it will have its own benefit. And terminologies and tools have to be understood by both the teams. Say, for instance, if I say pre-briefing, if I say something called scenario scripting, what do you want? The quality improvement person has to be able to understand these terminologies. And similarly, we don't understand any of the terminologies in quality improvement unless somebody has actually done a QI program. So when they say PDSA, it's like, well, what are we talking about? So terminologies and tools have to be understood by both the teams, and a strong link has to be created between simulation and quality improvement. So all this was beautifully put together in this article, where it was suggested that anybody, all healthcare professionals who have quality in mind, who want improvement in mind, who think that hospitals have to be safe place for everybody, need to get together. So we all have to work together. This is a revolution, because this is not, and one person cannot do this. So people who are working in silos, people who are spread and they are very small in number, cannot do this independently. But when everybody comes together, when we know that, okay, people are working towards this direction, and if I have a problem, I can always reach out to them and ask how they sorted this out, and vice versa, it always helps tremendously in whatever we are doing. And then there is, of course, some kind of validation to whatever we are doing. Okay, fine, we're not doing a wrong thing, because there's not much of research in this area. Many places are doing it, but it is not termed as simulation working along with quality improvement. But probably another 5 to 10 years down the line, there will be a uniformity. But currently, I think all of us have to work together. So reading more articles regarding quality, simulation together, and ensuring that more publications happen in these areas. Seeking out opportunities for doing courses or workshops. So a simulation expert shouldn't be only worried about doing a simulation course. They should be also going to QI methodological courses. And similarly, for a QI person, should just attend simulation course just to understand what is happening in that area. And when we all collaborate and engage with larger communities, definitely some kind of a positive movement in healthcare through simulation definitely can happen. And of course, all these together cannot happen without getting the managements, the hospital administrators, or the healthcare management into the picture. So the administrators have to be made to understand the importance of having a quality team. And if they have a quality team, then having a simulation expert or a simulation team is going to kind of multiply or exponentially increase the quality of care that they're going to give to the patients. And so this is something that the administrators have to be made to understand, because it's not something that is routinely known to everybody, and they don't come forward and do it off immediately. And also, a lot of research has to come from these two areas together. Now, it need not be hi-fi researchers. It need not be following up 1,000 patients or 3-year follow. They could be just small studies. And of course, these days, there are a lot of articles which are getting published. All posters relating to QI and simulation invariably get accepted to whichever conference we are applying. So these kind of research and where simulation and quality come together have to be more in number, and they have to be published well. Now we'll come to what the challenges are when we have to assess outcomes when we are doing research. So simulation experts are all well aware of the need of return on investment and also demonstrable patient outcomes. So what we all tend to do is to overemphasize on easily measurable time-based targets, and there is always an urge to show improvement. So we are always if we talk about bias, we are always looking at improvement to happen. We are hoping and praying when we do some intervention, that's definitely there should be improvement. So it's not like a very open thing where we go ahead and publish things that are not happening well. Of course, there are shortcomings of simulation, but we hardly find papers published on shortcomings of simulation. And hard clinical outcomes, say for instance, life being saved, or resuscitation done well. And so hard clinical outcomes are most visible. But the outcomes of simulation are not hard clinical outcomes. They are team performance, organizational culture, fostering relationships. Now, all these are very difficult to measure, and they don't lend themselves easily to the common QI measures. And hence, most of these outcomes are almost always underreported. And when we find that something works, it's really difficult to pinpoint what worked. I'm just going back to the same study that we discussed before by Ajmi et al., where there was a reduction in door to needle time from 27 minutes to 13 minutes when QI and simulation experts worked together. Now, why did they get that results? Was it because of the insightful debriefing that the facilitator did that improved team behavior or improved leadership among all these people? Or was it an increased familiarity with the real environment? So when a patient came in, they were actually it was easy for them to go ahead and do it. Or was it getting to know each other's names and faces through repeated low stress practice? So when they have to communicate, they don't have to call for a sister or a brother or stuff like that. They can just call by name. So the communication became more efficient. Or did the program actually act as a strong value signal for the organization and gave a clear message that improving stroke care was a priority? Probably a combination of all of these led to the results. And thing is, there are a lot more other things which could not be put in words. So when something works, we need to find out why it worked so that we can replicate it, like we previously mentioned. Even for research, that is important. Now, coming to how our healthcare infrastructure in India is, because if we have to implement it at the hospitals, now we have close to 1.5 lakh subcenters, 30,000 PHCs, about 6,000 community healthcare centers, 1,000 subdivisional hospitals, and district hospitals, about 700. So we should be able to start giving simulation-based training, at least starting from PHCs. But there is no formal training there. But what do we have in our country? The opportunity lies in the medical colleges, because of the 550 plus odd medical colleges that we have, only 11% are standalone postgraduate institutions, which means all the other medical colleges, because of the mandation by the NMC, already are equipped with simulation centers. So if these medical colleges start propagating simulation-based work, and if the tertiary care centers start doing simulation together with QI, then probably we can start escalating it down. Of course, it will be awesome if it starts from the PHCs or the CHCs or the district hospitals. If they can do it, it will be awesome. Of course, everybody can do it, because there is no need for a costly mannequin. There is no need for a heavy investment to run simulation. Simulation is purely a technique which, if taught and learned well, can be done even with really basic mannequins, and even without a mannequin, using simulated patients, these can be done. But the opportunity is in the medical colleges, but the challenge is how do we actually go to these areas to make them understand, one, simulation is important, quality improvement is important, and they have to work together in order to improve healthcare. So that is something that we need to explore. And after all these things, will simulation help actually in healthcare improvement? That is a question. And there is undoubtedly, the answer is yes. But we need more data to robustly say that it works. And in case it doesn't work, we again need data to find out why it doesn't work and what are we missing in that area. So we need to keep trying. We need to go and walk in that direction for us to understand how well or how much it is going to work. So in short, if I have to just put it in 3 lines, translational simulation is what all of us as simulation experts should aim at. Simulation experts and quality improvement experts should work together hand in hand, and we truly need to start looking at why things go right and replicate the right behaviors. So there are a lot of my teachers and people whom I look upon in the simulation field and outside also in the August audience. And I truly would love to hear everybody's experience in this field. And actually, I have more questions than answers. So I'm going to stop presenting, and thank you everybody for the wonderful opportunity.
Over to you, Dr. Rashmi.
Hi. Thank you so much, Thilaka. I mean, it was just magical. You know, I have actually filled up 2 pages of notes myself.
Thank you, ma'am.
So the fact you keep on saying that I am your teacher is no longer true. I actually have made notes of your lecture. And the thing that you told about translational studies was exceptional. That was something that even I didn't know. And I'm sure there are a lot of other simulation experts here in this August gathering. I can recognize a few names, and I'll open the house for the discussion also after Dr. Geeta's comments. And one thing that I do want to insist definitely is that simulation should never be practiced in islands. You know, we should never be known as people, these people are practicing simulation and these people are not practicing simulation. It has to be demystified. It has to become a kind of a culture in the whole department, between the departments, between the institutions. It has to become a culture. Then only we're going to kind of recognize the true potential that simulation has. And I'm sure the people who have joined from outside India would know that its advantages there in their clinical setups. But here in India, we're still struggling with this thing where it's still not demystified. We still feel that simulation is something that should be just done in the simulation centers or in the simulation labs, and the teachings and the learnings that are happening in those centers and the labs cannot be translated to the clinical practice. Even if there is no benefit, even if we cannot actually predict the clinical betterment of clinical outcomes in patients, the actual practice and the feel good factor of being able to do something with the patients, what we have learned in the simulation lab itself is an advantage of simulation. Yes, Dr. Geeta.
Thank you.
I must congratulate Dr. Thilaka. Wonderful, wonderful talk, Dr. Thilaka.
Thank you, ma'am.
Right. Yeah, about the simulation, just to reiterate what you said about, team building. There are 2 good articles. I think one which came in 1999, which is To Err as Human. I don't know if you know about it. It was by the International Institute of Medicine. And there they said teams that practice together, after they wrote the whole article, that it's mostly non-technical issues that lead to errors. And they said teams that work together, it is very important. Especially they've identified 3 fields, which is intensive care, emergency medicine, and in operation theater. That is where I'm sure the whole hospital works as a team, but this is where the team comes into focus more. And in that article, they said if you practice more as team, those, you builds familiarity, you have a certain trust factor, you have how to work in a team, and it brings out better patient outcome. And another book which I've read is the Atul Gawande book, which is Complications. It is something, even in that book, he says, it is just an amalgamation of what happens in the hospital environment. And in that book, he says 90% of the complications that occur is because of the non-technical issues, which is lack of communication, lack of team working, poor leadership, and poor decision making. And he says all this can be overcome with simulation. Of course, he doesn't say that. And people who have practiced it use that book as an example to say only if they'd worked together and thought as in a different angle, it would have probably been better. And there are a few studies which have said that simulation does help in outcome. And we in our center, we did a very little small study on our own where we practiced on the novices mask holding technique only for our interns. And we didn't publish it, of course, because we did only for about 15 people. And we found that when we got them into theater, their skills were so much more better. Small skills like this. And even with our OT technicians, what we do is we do not take them to the simulation center, but we do practice in the thing, kind of, role play. Sorry?
I think so.
Dr. Nesa, could you, Dr. Nesa, could you please mute yourself?
Yeah. Okay. And that I feel is a thing. And I think with that few words, I will open it to the forum.
Yeah. We have Dr. Thilaka, who's a simulation expert logged in, but he's supposed to be in a cab on his way to Pondi. Dr. Thilaka, are you in a position to speak?
Yeah, I can speak.
Yeah.
So as usual, Thilaka's given a wonderful talk. I've had the pleasure of hearing her before, and she never ceases to surprise me because for every topic, she brings in a fresh perspective and fresh insights. And like you, Dr. Rashmi, I have learned a lot from this particular talk that she has given. And I think it is high time we started emphasizing this aspect of simulation, which is translational simulation and improvement of patient safety through quality initiatives. And I have worked in a number of institutions where there is a member of, in fact, I had gone to King Fahd Medical City in Saudi Arabia for accreditation. And it was good to see that they have a member of the simulation team on the quality assurance board, and vice versa. There's a member from quality assurance on the simulation center team as well. So all issues that happen in the hospital are brought in to the simulation area, and then they recreate it, and so that they improve the quality in the hospital. I think that is a sort of integration that we should be looking at. And I think she also mentioned in passing about the value of simulation in people getting to know each other. I remember in Singapore, we had, we were having issues with trauma resuscitation. And so we decided to run a series of simulations to improve that. And so we ran in the emergency in situ simulation, we ran for polytrauma. And we called in the orthopedicians, the general surgeons, and all the people, the trauma team in general, and we activated them as would happen in the real case of trauma. And 6 months after this intervention, we found that trauma care improved tremendously in the hospital. And when we look back, the main reason why trauma care improved was much less to do with our simulation, but much more to do with the fact that they started knowing each other. Otherwise, the orthopedic surgeon didn't know the emergency physician, who didn't know the surgeon. So every time they would be at loggerheads. Why did you call me before taking the X-ray? Why did you call me so late? Those sort of interpersonal conflicts were happening all the time. Those disappeared simply because they became friends during the simulation exercises. And that itself led to a tremendous improvement in quality. So I'm glad that you highlighted that. Thank you again for a wonderful talk.
Thank you so much, sir. Thank you, Rashmi ma'am and Geeta ma'am. Thank you so much. It's really it's really overwhelming and very humbling to hear from people like all of you telling such things. Thank you so much for sharing sharing your experience, sir.
So we have Dr. Soma Ganesh, who's recently trained in simulation, and he's also supposed to be talking on marvelous medicine soon. Soma, your take on what transpired today?
It was an absolutely wonderful presentation, Thilaka. I totally agree with whatever you have said. So when I was doing my fellowship in simulation, fortunately, the chief medical officer was the former director of simulation center. She's so much into simulation. She travels widely to different countries to look into the quality aspect. So she has made a thought of integrating quality as well as along with a part of the simulation center. So with each and every quality problem that's happening at the hospital setting, she used to make sure that a simulation exercise being given to the concerned individual. So there are a couple of lots of incidents like there was an oxygen cylinder which is kept in a different place. The staff has to travel quite a bit to get the oxygen cylinder in a labor room, in a particular room. So that was picked up as a small latency, and then we did a simulation exercise for all the staff, and then they had a wonderful debriefing and found out the optimal place where everyone can approach it. And in that process, they got to know each other, and that helped in other aspects of patient care. It's not just in keeping a cylinder in a corner. And there are lots of small exercises we did, like giving in the taking all the nurses who are diabetic, who are particularly taking care of diabetic patients from the community, and then we train them as part of improving the quality of care that they receive at their homes, especially the elderly geriatric patients. It made a tremendous difference. And the Care Quality Commission that gives the NHS a rating and all. So after the quality improvement, the quality and the simulation departments started working together. The CQC rating of the particular trust which I've worked with has improved tremendously in many areas. And one of the important things is the team building and the interpersonal relationships and the communication with each other that has improved a lot when such exercises are there. So the work culture improves for better. And we found that the stress among the healthcare workers has reduced tremendously, especially in people who are working in emergency department as well as in the anesthesia department, which are the high-risk areas, such as the acute care settings where lots of events happen. So I think there's lots and lots of literature backing up. The thing is, certain quality things cannot be measured or they cannot be quantified to say that this has improved by so much percentage or something. Certain things are better felt rather than said. So if the simulation works in tandem with the quality improvement department, it will transform the entire hospital, the entire healthcare setting into a beautiful work culture that will have a long run. In a long run, it will even place the entire healthcare setting on and forward in the quality of care as well as the continuity of care the patient receives. I think I summed it up. And one of the important things is about human factors that can be tremendously improved along with simulation training. I'm not talking about it because I'm going to talk about it in my talk. Yeah, I think, thank you very much.
Thank you so much.
Thanks, Soma. Dr. Radha had a question which probably Dr. Geeta can address. Are obstetric emergencies like PPH and deep transverse arrest featured in your program? Dr. Geeta, you're muted.
PPH is part of our simulation scenarios, which we do. And we usually get one of our obstetrician team and the obstetric PGs to be a part of our this one. Deep transverse arrest, no, we haven't done it. That's food for thought for us. Probably we'll develop one scenario, because writing the scenario, developing it, and seeing if it really works takes a little bit of planning to do.
Dr. Jayashree Gopal wants to know whether you have developed courses on topics like breaking bad news. So, Thilaka, do you want to take that?
Yes, ma'am. When we identified, so what happens is originally the concept in simulation is we try to give the knowledge and skills first, and then we bring them to an area where they can practice decision making, team behavior, and we can look at their attitudes, communication, and their team performance. But what originally happens when we train students is how much ever we give them reading materials and everything, they don't kind of come prepared. So from the simulation sessions, we take a lot of inputs on where we have to do the courses. So one of the areas when we identified was communication and breaking bad news. So what in our system we have done is, because we saw that it was a consistent thing throughout all teams, we have made it a mandatory training as soon as they enter. So the induction program itself has a communication and breaking bad news session as a learning module, as well as a role play and simulation given to them. So all students will get communications, breaking bad news. And there are challenges when we deliver things like communication, because if we don't have an absolutely amazing facilitator who understands challenges in communication, so it's not like a normal technical skill where it is written in textbooks, but we need to have people who have been in the system. So we need to have that kind of a facilitator with a clear knowledge on what is important in communication, and they should also be simulation trained so that they'll be able to deliver it in a simulation way. So what we do is we combine it with didactics as well as role plays, and we show them videos and then debrief with the videos. So yes, ma'am, we do have that. Even a session of say 2.5 hours tremendously helps the learners.
Can
Right.
I just add one word to what Thilaka said? Thilaka,
Absolutely, ma'am.
Yeah.
Please.
as a I'm sure the medical colleges professors who are here, or people who are associated with medical college will know that NMC now has mandated ATCOM as a learning module in the foundation course. That's in the first 1.5 years, and it kind of improves to the subsequent years. And ATCOM is an acronym for Attitude, Ethics, and Communication. It's part of the syllabus now. And they've made it compulsory that certain hours are dedicated in each term. And they're assessed, of course, on the communication scale, and they're given feedback on that as well. And this probably will play a good role to them.
Thank you, Dr. Geeta. Dr. Jayashree Gopal has her hand up. You want to say something, Dr. Jayashree?
Yeah, sorry. Thilaka, I really enjoyed your talk and nice to meet you. And thank you. I mean, this is an absolutely fascinating new field. My son went through this in his foundation course. And what I felt was, I think it's just too early for them to even undergo anything like this. They have no context. I think the reason I was asking this is, I think it's extraordinarily helpful. It would have been helpful when I was a junior doctor, when I was even now, even today. I think we all still struggle with, after so many years in practice, we still struggle with breaking bad news. And we always wonder, are we doing it the right way? And it's a constant struggle. So I was wondering, have you developed anything that we can use in the hospital setting? I mean, you work even a corporate hospital like that, where we have to do this every day. Have you developed anything was really my question. Not so much what for the medical students. Thank you.
Thank you, ma'am. So yes, ma'am, we have like the place. Our center doesn't have undergraduate students. We have only postgraduate students. So the communication is mainly tailor-made to suit people who work in the hospital. But like I mentioned, only a facilitator who can. So even if we have the modules and we go ahead and share the modules, the facilitation bit is what will probably make a difference. So if we have somebody who has a clear understanding of how to translate this communication, then the modules will tremendously help them. Yes, we do have modules, ma'am.
So,
Thank you.
Dr. Rashmi, there was a question. I mean, I was just wondering whether you've done that. Dr. Radha Pandian has asked, have you followed up with trainees, how they fare in real clinical scenarios after, see, the All India Institute of Medical Science will have every gadget. The SIM center will be one level higher than probably even the OR. But what happens to these people when they go to, say, Tripura or in Jharkhand or somewhere, and they have to practice? How do these things work? Do they feel empowered because of the simulation sessions? You have some feedback on that?
Yes. Thank you for asking, Dr. Vidya. See, empowerment comes because, been there, done that feeling. Okay, so you've seen anaphylaxis happening in the simulation lab. So, you've been kind of given the technical knowledge about how to handle anaphylaxis. And the empowerment regarding their own behavior would come only after they attend a good debriefing. So again, with simulation, unless it is attached with a good debriefing session with the facilitator, like for the communication modules that Thilaka was mentioning, a good facilitator is very important. So here again, a good debriefing is very important for them to feel actually, empowered to handle a situation where where they feel that they are in control of the situation. So yes, they feel empowered because they've seen the technical aspect of it. Like they've seen the pneumothorax, they've seen an arrest situation, they've seen anaphylaxis, they've seen high spinal anesthesia. But whether they can actually handle the stress in real patients, because now it's a real scenario, and have they talked about this with the debriefer uh, during the debriefing session, and let go of their inhibitions, then only it can be handled in actual situations. But I definitely do not have any data regarding this, and I'm hoping that it would have been helpful for them. But it's a good food for thought, and yes, we should follow up with our students whether it has really helped them.
So I'd like to bring Dr. Dinkar Pai again here, because I remember over some faculty dinner or something we were discussing how almost the well conducted simulation and a good debriefing can be so intense that, because in our hospital when we do simulation, many people say they are unable to take it seriously, like mock drill, especially not a little bit different than regular simulation training. Mock drill, when you say code blue in this ward, they just, somebody comes and laughs or somebody does something because they are seeing a mannequin. They don't seem to feel the need to perform the best way. But the other end of a spectrum, like Thilaka mentioned, when you have a good facilitator, so Dinkar once shared a story about how almost he had to do grief counseling for those for the team which had undergone simulation and which had had a bad outcome. So Dinkar, would you like to talk a bit about that, about debriefing?
Yeah, I think basically I'm fully in agreement with whatever has been said so far in terms of the importance of simulation as a package, which includes debriefing as the most important component of that package. And as you rightly pointed out, the challenge to facilitators and the expertise of facilitators comes in how to draw the participants into the simulation, where they sort of believe that what they are doing is real, the so-called fiction contract. And that is where the skill of the facilitator lies. And basically, you need to do two things for that. One, the scenario should be grounded in reality. In other words, the scenario should be depicting something that is real to them, that they face every day in the clinical environment, so that it doesn't look very strange to them and outlandish. And the second thing is, of course, the skill of the facilitator in making sure, in designing the scenario in such a way that the participants are totally involved and they believe what they're doing is real. So I think these two go hand in hand. And as you rightly pointed out, I've seen senior, this was an associate professor of anesthesia who was practically moved to tears because he couldn't save the patient. And in fact, we were doing this in a very artificial environment where it was in a big hall where people were sitting. I had gone to that institution to train them on simulation. So we were not in a separate control room. We were controlling the mannequin from the same room with just a sort of cloth screen between us and where the action was happening. And this guy, when nothing was working for the patient, he got so agitated. He came running, pulled down that cloth screen, and he was saying, "What am I doing? What do I need to do? I'm not able to save the patient." So it can be quite intense, and I think it is the skill of the facilitator and the realism of the scenario which makes it so. Thank you.
So, Ilango, you've been awfully quiet. Your thoughts, Ilango Setu.
Ma'am, can you hear me? No, it's not just that. I was just thinking of several points she made up during the talk. It was a wonderful talk, Dr. Thilaka. My focus has always been on simulation for decision making. I think I did a lot of work when I was in the University of Pittsburgh when we wanted to train for skills. One of the most difficult surgeries for training is liver transplant surgery. The biggest trouble in training is that when you actually are starting liver transplantation, you make a mistake, it can cost the patient his life, his or her life. So a lot of trainers are very reluctant to train people to do that. So when I was the first year fellow in the University of Pittsburgh, we had an issue with a couple of our seniors. They were doing a technique, which is probably not relevant in this forum. That technique was, they were finding it was one of the easiest ones. They were finding it very difficult to connect the liver. So I decided that simulation training for skills was very much required in a high stress environment. So we worked on a model and created some things, and we practiced on them. And one of the senior consultants came and said, "This is not how you learn liver transplant." So what he did was he used to stand by the side and sprinkle water. It was a big disturbance for all of us when we were working on small needles. And then when we got enough agitation, he said, the worst thing you can do is put colored water on that, because that is the environment in which you're going to train for. So I realized that when you train for skills, you train for a certain set in a controlled environment, which will enhance your skills, but the actual efficiency is something doubtful. It was very helpful for me, but I found 3 other of my colleagues have completely lost interest in that, and they stopped doing it long time back. Barring that, the current deficiency I find in the Indian system is the simulation for decision making. I have also been working on MBBS training recently as a part of this work in LGS. MBBS training does not train you to make good decisions at the basic level. But these people are, after the MBBS, they are put as medical officers in charge in PHCs, where they are supposed to make decisions and implement healthcare policies, probably with or without a senior supervision. That is a big and major challenge now. They don't know the waypoints and they don't know how to make those decisions, and there is not much documents to help them off. Some of the files that you read from the government of India is so huge for them to translate, and the skill level at that stage of training is difficult. So I work on that. Have you ever tried anything like that in any of the simulation centers which you have worked on?
When we do the scenarios, when we conduct the scenarios, we put critical areas where the learners will have to choose a team leader. The team leader will have to make decisions, and their decisions will have implications. We don't, at least for me, I don't deliberately do decision making as a simulation exercise, but as part of the simulation exercise. For instance, there is a patient with tachycardia and some mild ST change. So when do they decide to call for the cardiologist? When do they decide to ask for an ECG? When do they send for a tropi? How do they decide what this patient requires? So that becomes part of a scenario of how, so the learning outcome would not be decision making. The learning outcome would be how they manage a patient who's wheeled in with the chest pain, and how do they function as a team, and how do they escalate it to the next level. Only decision making as learning objective, at least I haven't tried, but it's a very interesting thought, and I'll definitely work on it. Probably the next time we meet, I'll tell you if it worked and how it worked.
Thank you.
Dr. Ashmi, would you like to take that question as well?
Okay, so we run our simulation programs for our postgraduate students. And like I said, since simulation is not practiced in our clinical areas. In fact, what I feel is that unless people take up debriefing regularly in their clinical practice, it would be difficult for them to take up simulation in their clinical practice. So the scenarios that we run are for our postgraduate students, and it would require decision making, but in their hearts, they know that when it happens in the theater, they are not the people who are making the decisions. So they are always the junior residents, and they would always be a consultant, they would always be a senior resident. But their level of decision making, like calling for help and starting an IV line, that they of course feel empowered to do all that with their patients, but not the decisions which are going to majorly affect patient outcomes.
So, Soma, you have your hand up. You want to
Ma'am,
say?
can I
Yeah, go right ahead.
Dr. Rashmi, I personally disagree with most of the teachers on this. That means we should not actually reward a postgraduate degree at the end of 3 years. I think we should teach them basically the decision making for the entire package. Obviously, there is a supervision. They are going to make mistakes. We are going to correct them. But the decision making, they should know. If they don't know that, they cannot be qualified doctors. And I actually disagree with a lot. I mean, I work with Dr. Surendran, and sometimes he says, these postgraduate students are not capable of operating independently. And I always tell him, that's the mistake of the teacher. You are a responsible person. So that you have to have very clear ideas. This simulation will help them imagine and tackle a situation which they will face in a different point in life, where they have to make the right decision, which will help a patient. So that's how I see it. So I think the presence of a senior probably should correct the wrong decision, but should not prevent them from making the right decision. The student must know that.
I think you kind of misunderstood what I said. I just said that in the clinical environment, they are not the decision-making people, but when we do bring them to the simulation lab, they are the decision-making people. So there they get the chance to make decisions and make errors and correct the errors. And in the debriefing session, kind of discuss with us whether the decisions that they had taken independently were correct or incorrect, or in the real life, how are they going to behave? Yes, they do it, but whether it is going to help them handle a real situation when they become senior residents, when they become responsible people, I would think that it is helping them, because otherwise, why would we be doing simulation? But I definitely do not have data kind of corroborating it.
So like Thilaka spoke about integrating quality improvement and simulation. I think unless we integrate clinical scenario education with simulation, is not going to work. So even in the OR, I think the point Ilango was trying to make, that even in the OR, let's just take anesthesia an example, since most of us talking a lot today are anesthetic. So we have to give the decision making at least the option, or even maybe force the taking the decision. Whether the decision is implemented will rest on the senior around, like Ilango says. If it's a wrong decision, maybe we don't implement the decision, because I don't have undergraduates, I don't have postgraduates. I get very often people who have just finished their anesthesia and they join me as registrars or whatever. So the first thing when we go in, they said, what do you want me to give? Should I do this or should I do that? I said, you tell me what you want to do. If I don't agree with, if both of us agree, we go ahead with it. If we don't agree, I tell you why I don't agree with you, and you can tell me why you think what you said was right. That, imagine a qualified anesthesiologist with an MD degree behind his name or her name hesitates to take any decision about anything just because the senior is around, which means somewhere we are, somewhere we are not doing the right thing. So I think that even in the OR, in the real situation, they should be asked, if they don't do it themselves, they should be asked to speak up about their what decision they would take. Implementation, obviously, if you think it's wrong, the senior person is not going to allow it. So that's my 2 cents. But Soma, you have your hand up.
Yeah, I think what Dr. Ilango raised is a pertinent point about simulation for decision making. So I have worked with a couple of trainees in UK who are international medical graduates, and then they moved to UK. So most of them have done their undergraduate program in different parts of the world, many from Africa, Asia, and few from Caribbean, South America, US, Mexico, Canada. And so when we group in all of them together and to give a program, so we run series of programs for a week called an impact program. So for them, when we teach them, when we try to teach them, even a simple scenario like in treatment of an bronchial asthma in an emergency room setting or an anaphylaxis inside the operating room, the guidelines, the protocols, everything is simple and straightforward and clearly given. But then when it comes into the practice, the translational translating the guidelines into the clinical practice, there's lots of variances, there's lots of hesitation. So some from Africa will feel that the nurse, I have to order the nurse to get the drug to be given. And some from UK or from Western country would just request the staff nurse. And some from Asia, they themselves will take and they will put on the nebulization. So the decision making to whether to instruct a nurse or to go and do it, it's such a simple thing, but it's layered with so many thought processes deep within. So when we tailor made the decision making process of how things work in NHS, and what is the accepted good clinical practice in that clinical environment, so that the decision making can be done for better. It's universally acceptable across every people in the hospital, and how the flow of communication is much better. So it's just giving an nebulization of an salbutamol is taking such a decision is difficult, and when it translates to when we need to talk about liver transplant surgery, it's going to be too difficult. But then it is not a too difficult task. So I have worked with a couple of the AR, VR, of the virtual reality, where we have lots of modules where the patients, if we can go through the modules, it's actually we use it for undergraduate training, and for few postgraduate training, few models like breaking bad news or managing complex situations and coming out of coping up with stressful situations when you are faced with an on-table death and so on. So when we use those modules and when they take decisions, and then we try to incorporate, we try to find the mental models, why they took that decision, and what is the thought process behind those decisions, and how they can improve upon it. So simulation is a wonderful tool to train people in decision making. So for all these things, as I think Dr. Muthaiah has said beautifully, the role of a facilitator or an debriefer is of much important and essential. The moment a good facilitator or a debriefer comes into the picture, it is very easy to facilitate the learner to take decision making in an appropriate way. In one of the simulations which we did in the northeastern England in a nuclear power plant, so we had an emergency where the radioactive material is supposed to leak to the environment, and we were running a simulation scenario. And then there's a guy who has to open up the key and flood the reactor. And before flooding the reactor, he has to get permission from the senior level manager. The moment the alarm was found, he started hearing alarm, he was stunned. He didn't know, because he has not heard that alarm for the past 4 or 5 years, that there is a life-threatening emergency, the radioactive material is leaking. So he was stunned and he couldn't take a proper decision. So he started calling his senior over phone, who could not be reachable for the 15-20 minutes, which is a very valuable time where we don't want the radioactive material to be spilled out. And then we did a debriefing and found that whenever he's faced with such a stressful situation, his decision-making skills are hampered. Obviously, it's going to be the same for most of the human beings. And then we did a couple of debriefing sessions, and then a team training exercise was done for him, so that if such a real life experience happens, then how he has to take forward. So I think simulation plays a wonderful role in decision making. It's all up to the objectives that we are going to have for that particular scenario, or for that particular program, or for whichever the objectives, the goal which we want to achieve. I think it's very easy if we tailor make the program for the needs of the learner. Yeah, I think Dinkar Paithar is raising his hand. The floor is open for you, sir.
Dinka, you're muted.
Yeah, thank you. I just got home, sorry. So basically, I agree with what Dr. Ilengo was saying. I think decision making is an integral part of medical practice. It is probably only the level of decision making that will differ from junior to senior levels. And I think what we need to do is, for every simulation that we run, ultimately everything depends upon the simulation scenario is designed according to the learning outcomes. And one of the learning outcomes should be, there should be elements of decision making in the learning outcomes of the simulation scenario. And this should be guided by what we observe day to day in the clinical area, where we find which are the areas where our juniors are having difficulty in making decisions. It's very easy to replicate that in the simulation center by designing an appropriate scenario. And I think one of the very important decisions that we need to teach our juniors, which probably is not emphasized enough, is when to call for help. Call for help early and when to call for help. And that itself is a major decision, which I think everybody from junior to senior needs to learn. We have run simulations for undergraduate medical students on primary assessment and stabilization of trauma, where one of the things they had to do was to take decisions which they perhaps would not take by themselves in the clinical area. But it was heartening to note, this was anecdotal evidence, of course, when they became interns and later on when they got back to us and they said that these sessions had helped them to take decisions, not only in the area of trauma, but in other critical events as well. So I think it's important to include decision making in all our simulations, and the level of the decision making can be appropriate to the level of the learner. Thank you.
So Ravi, you're kind of far removed from this situation these days, but what is your takeaway? Ravi Shankar?
Trouble. Yeah, sorry, I was having trouble unmuting myself. No, I mean, I personally believe that all of this actually does impact how people make decisions. And I think what Dinkar just said anecdotally needs to be captured, hopefully with a publication that will show how useful these are in real life. So that's the best way of doing it. It's like how we've looked at modeling and simulation in many different areas. It started out, at least in the medical field, in the biostatistics area, and it's really something that a lot of us use without any skepticism anymore, right? Or a lot less than it was, say, 10, 15 years ago. So I think the same thing can be said for simulation in teaching. I do believe that Dinkar and everybody else, and Thilaka, all of you who are doing, doing pioneering work, you will see the results of what you're sowing right now in a few years.
Thank you, sir.
Yeah, Radhakrishna?
Yeah, it's a wonderful evening, great lecture and excellent discussion. But firstly, I'm surprised that all the simulation specialists are anesthetists. I don't know why it's that, excepting with Dinakar is an exception or an aberration, maybe. I'm interested to know why is that. Having said that, the surgeons and surgical skill is a lot to do with simulation, and that's what it's a so instrument heavy specialty now that these simulations become so very important. Now, I don't know what percentage of undergraduates and postgraduates medical in India heard of the term simulation and go through that at all, because I've seen great centers starting at Thorny Institute, JIPMO, Pondicherry, and a couple of state-of-the-art centers, one Rajahmundry, one in Pune, one in Mysore. But majority of the government medical colleges do not have anything to do or anything of a simulation or a faculty in simulation, because I think that is the need of the hour, especially with the undergraduate seats and postgraduate seats increase so much and the patient material has become so very less. This is, I think, very topical, this topic. And I think, as everybody mentioned, that this should be a part of undergraduate and postgraduate curriculum, and everybody has to log in a certain hours in simulation before they are given a pass. I mean, that's my takeaway.
Dr. Geeta, you were trying to say something.
Yeah. Just to add on to what Sir was saying, and now NMC has mandated that all medical colleges which have undergraduate training should have a skills lab at whatever capacity, if not state of the art, the most modern one, they should be having a skills lab. And I think most colleges, at least in the tier 1 cities, most government medical colleges do have a skill lab and then skills lab, sir.
Okay.
But they do have simulation lab. This is what I've learned from in Karnataka that I know. I think the one in Mandya is developing one. Mysore Medical College has, Bangalore Medical College has. So a few of the colleges that I have interacted with, they do have it. And few other centers like standalone DNB institutes also have skills lab now. Thilaka, I think you would agree with me.
Yes, ma'am. Dinkar sir has raised his hand, so I'll probably talk after he finishes. Yes, sir. Please, sir.
Yeah, thank you. I have traveled extensively throughout this country and I've visited many institutions. And unfortunately, the reality is that the simulation so-called skills labs are observed more in the breach than in reality. A lot of the, what I have observed is there are three categories of institutions. One, which is a minority, like MS Ramaya, like JSS Mysore, are the ones who believe in simulation. They have simulation centers where they are seriously training students using simulation and getting quite a lot of success with it. The other category is those who use a simulation center as a showpiece for attracting students to their medical school, where the simulation center is generally kept locked up and opened only when visitors come, to show them we have all this. And the third category, of course, is those who don't have anything at all, and they will get these mannequins on rent whenever NMC is visiting. And then, as soon as NMC goes, the mannequins go back to wherever they came from. Even the EdCom module, which I have seen observed in a lot of colleges, of course, I can't blame them because this was sort of rushed through in a hurry, especially during COVID. And if you know, the curriculum is applicable to our students which were very badly COVID affected in terms of their medical teaching career. For the first 2-3 years of their career, they hardly had any patient contact or anything. So these AdCom modules are also, just to rush, the foundation was just rushed through in the series of lectures, which is probably not the ideal way of teaching AdCom. So we in our institution are making a deliberate attempt to spread out the AdCom module over many sessions and using simulated patients. We are very active in the SP methodology in our institution, and we are using simulated patients to interact with the students for the, for the AdCom modules. So I think a lot has happened because of the NMC curriculum, but as usual, a lot of medical schools are just trying to just fulfill the minimum requirements just to satisfy the inspectors rather than actually trying to make a meaningful difference in terms of using simulation as a modality for education. I think that mindset needs to change.
But I have a question.
Sorry.
Is there any postgraduate course in simulation? Who are the teachers who are coming in? Because there is a bigger need for that, and where are they get trained? And what is Thilaka's training?
Yes, sir. So I'll just add to what Dinkar sir and your question as well. So it's actually not about having a simulation center or a skills lab, sir. It's about how it is being utilized in student training. So for that, like you rightly pointed out, we need people who are subject experts. We need those subject experts to be good teachers, and we need those teachers to undergo a formulated method of simulation training. So a minimum requirement for anybody who enters simulation would be to at least do a faculty development program, because though clinical teaching is done well and though teachers are amazing at imparting knowledge, using simulation and imparting knowledge using a mannequin is an art, or it's a science in its own, which is still exploring various things. So a minimum faculty development program in simulation is definitely required. And then from there is no such thing as a fellow, at least to the best of my knowledge, in India. There is no such thing as a fellowship in simulation. Maybe they are available elsewhere in the world. But what we all try to do is we learn with each other. We learn from our mentors. We learn by doing. And then we start attending the slightly more advanced workshops, say, for instance, an advanced debriefing workshop or an advanced simulation training. And so that is how most of us do. So there is definitely no post-graduation in simulation or a specialized residency program in simulation, at least as of now in India. Again, I'm not sure about the Western world. But the good point about India is, whenever we run a simulation program, we see a lot of people embracing simulation immediately, understanding the fact that it actually works and willing to learn more to become teachers in simulation. So just like how we have a challenge of all skills lab not being utilized properly, we have an equal opportunity among all these enthusiastic teachers who are not essentially in the very high rung of teaching. Say, for instance, they're not the associates or the professors, they're just tutors, but they want to take it up. So so currently it's only a faculty development program, and we take it forward from there, sir.
So is the situation different? Because 5 to 10 years ago, before NMC made it mandated, there were a handful of very advanced simulation centers, even in JIPMA apparently, which was, it's not that it was locked up, it was open, but there was nobody going in there to do anything. Has the situation changed, or is it still the same? Because where people want to, people need mannequins, people want skill lab, they don't have it. But the people who have everything don't seem to bother to use it. Has anything changed over the past 5 years?
I can probably talk about the corporate sector where I am working currently, ma'am. So there is no dearth of people's willingness, and there is no dearth of equipment and mannequin available. The only thing that is a problem is time. How do they specifically take out particular time for simulation? Because the only place where the teacher cannot just ask questions, like when we do a facilitation, I am more concerned about the students, whether I will be able to conduct the facilitated discussion in a way that will help the students. So it's not a one-way communication. We have to get them to talk. So it is an exercise which involves time. Designing a scenario, setting a curriculum in simulation. So time is the problem in corporate sector. With the medical colleges, at least as far as I know, a lot of our friends are doing simulation-based work, and there is definitely 100% there is scope of improvement. But I'm sure it's not like how you're mentioning 5 years back, where the skill centers are just left open and nobody is using it. It has increased, but it should increase tremendously.
But Thilaka, a strange question. I'm surprised how a corporate hospital starts a simulation center. Whatever corporate does is to make money. And what is the idea behind starting a simulation center?
So we run a DNB program, sir. So basically, it's the vision that comes from the leadership. So when the leadership, they go out and they see simulation centers elsewhere, and they understand that our students and our doctors should get this kind of training. So they kind of translate it. At least for our simulation center, the director, our director, who's Dr. Muralidharan, kind of implemented it. So when the leadership says there should be that one person who will take it up and who will ensure that the simulation goes from just a dream to reality in a corporate sector, because they are aware that when patients are happy, they come back to us and they refer more patients, and it kind of improves quality and reducing errors, making hospitals safe, ensuring good quality training so that we attract better students to our postgraduate curriculum. All these are definitely areas which hospitals are worried about. Corporate hospitals are the administrative level of corporate hospitals are always concerned about getting the right kind of students. So but it took about I think it took 7 to 8 years for this to come true, at least in our sector.
So MS Ramaya is one of the earliest private enterprises to get a. So how did all that happen, Dr. Geeta?
I think we started our it's 10 years now. 2012 was when we started our simulation center. We called it Advanced Learning Center. There was kind of people were shifting laterally, and our chairman visited. I think he went with one of the administrators. He traveled to Chicago. They were looking to sign into some MOU, and they happened to see the skills lab. And the moment he came back, he said he shifted our medical director. He gave him full power. He said, you open an advanced learning center with the skills lab. And that was where it started. And I think Dr. Sundaresh, who was in charge of the advanced learning center, took it to another level. And apart from the simulation and the other mannequin-based teaching that we have, there's something else that MS Ramaya has is the cadaveric lab. There's a lot of training that is going on in the cadaveric lab, even though I agree that it's not simulation of quality training, which Thilaka was emphasizing all this while. It is more to the surgeons to develop skills on the cadaver. And in fact, I think we are one of the centers which even offers a Da Vinci cadaveric skills lab as well for people. And it comes with a cost, of course, yes. But, and it is a single person who trains for the whole day, and he learns from an expert on the cadaver with the Da Vinci robotic skills. That is something very unique to Ramaya. So it's all been taken, they're taking it to another level. And to be honest, now that we have all these single skill-based mannequins, it's gone out of this one. We're trying to get new mannequins in and new equipments in. Hopefully we'll be able to do it. Because the newer centers, I think the equipments are much better.
So the skill lab is only as good as, or the sim lab is only as good as the facilitator, and they don't come any better than you. So what drew each of you, Rashmi, Geeta, you're probably roughly contemporaries, Thilaka probably a lot younger.
Yeah.
How did you get drawn into simulation?
I think as the first and foremost, which kind of attracted me was the whole process where I had to unlearn a lot of things of not just instructing, facilitating. That was an art in itself. And I'm still a work in progress. I'm not yet there. I have to get there. So that was something which I tried to get it. And being a part of the ACLS and the trauma life support skill helped me a little, because there, in fact, it is the debriefing session or the facilitating session that you have is a lot different from what it is in the medical school. The medical school, it's more instruction. But this kind of helped, to bring out answers from the students, what they would do, and kind of help the answers out of them instead of us giving out the answers. That is something which has made me, and I think it has come into my way of teaching in the bedside clinics also now.
So simulation depends on the needs of the students. So when I was doing my MBBS, we never heard of mannequins, and we were all learning on the patients themselves. So nowadays we would not like our MBBS students to directly come and start putting an IV cannula on a patient. We would like them to go through a mannequin and practice in the lab and then come to the patients. So similarly, when we start thinking about skills like communication, skills like leadership skills, skills like non-technical skills like decision making are important, and they have to be learned before they interact with the patient. And we will start introducing simulation for those non-technical skills as well. So I think we have we have the road defined in front of us. We are traveling on that road. Of course, a lot needs to be learned. We are like Dr. Geeta, everyone is learning. Even now, we learn with each scenario that we run for our students. So, but we'll reach there someday.
Is there a national association of simulation specialists? Is there any group or anything of that sort?
I don't think so. I'm not aware of it.
So there is a group called PediStars. Both me and Thilaka have gone through PediStars. PediStars is mainly run by pediatricians in our country, but a lot of anesthetists are part of it. And we really like their program, and it's really very progressive. And they do run, I think, yearly programs every year. They do have a yearly conference. Thilaka?
There are other groups also, ma'am, like the Society for Healthcare Simulation, SHS. There are groups, both, there are international groups and there are national groups as well, sir.
Oh, okay. I'm not part of any. I should become, I think, now.
So unlike Dr. Geeta and Rashmi, Thilaka, I understand that you've completely given up clinical practice and taken up simulation full time. That would have been a major decision, right? These two people are still there on both the sides. So how did you just plunge into simulation totally, like?
I got drawn into simulation because of a few simulation scenarios that were run by Dr. Rashmi and along with Dr. Vimi. So I still remember the first scenario that I was sitting. I was like, what? You don't even know that? How could you even miss that? I think so. That was the kind of reaction that I had, and both of them pulled me to the side and said, see, Thilaka, that's not how. So they kind of held my hands and got me into simulation. And Dr. Rashmi completely pulled and drew me into simulation when I was at AIMS. There was the one Dr. Diorari always used to tell you have to combine simulation and QA. So that thought somehow kind of intrigued. Got something inside me right from AIMS. So when the shift from Delhi to Chennai had to happen, the Apollo Simulation Center was opening, and I was not planning on giving up clinical medicine. I was just thinking about, so this kind of became one passion. With no reason. There's no reason that led to this. So if we could do something that can make healthcare safe for each and every patient who walks inside the hospital, irrespective of whichever hospital they walk into, irrespective of whichever time they walk into, because the number of errors, like today I have to go to a hospital, I'm more than scared. I keep wondering if people around, if there are people who know me well. So it's not because of any one person, it's not because of any one thing, but it's generally a system of safety. It's a culture of safety. So simulation looked like an amazing tool where we could do this. So that was the reason why I entered into simulation. And the place I work right now, and my boss, Dr. Muralidharan, and the leadership of Apollo helps us do that in it's not just about upskilling. So if we have to talk about quality, if we want to talk about safety, we are allowed full access to all of the hospitals. So any clinical area, if we want to do any kind of training, and if we want to proceed, and if there is some kind of purpose. So so because there is purpose, because I see that there is some change happening, though I can't put it down as a data. That is the reason why I'm still in simulation, and I want to do further in simulation. Of course, clinical practice is not off the plate. Probably 6 months or 8 months down the line, I might want to do both.
So we are really out of time. Thank you, Thilaka, for that stimulating talk, and thank you, Dr. Geeta and Dr. Rashmi, for joining in with all your insights. Thank you everyone for logging in and making this program. Special thanks to Soma and others who contributed. Dinkar had to leave, so I will thank him one-on-one. We'll meet again next week with yet another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Thank you, ma'am. Good night.
Good night. Thank you.